So I congratulate ISA Vizag for this new edition of something totally novel in our city, and I also thank them for inviting me to this edition of anesthesia. I have no disclosures to make, except that airway management is also the primary. If there is a key message from here, this is not about me or airway management or my expertise or lack of it. Airway management is not skill alone. That's so. What I say is my personal opinion, may not be everybody's opinion. So do listen to this presentation with an open mind, but also take it with a pinch of salt. So the first thing that anybody would like to ask when you do this kind of presentation is to ask who really is difficult to intubate. So we'll use a particular case. At HBCHRC Vizag, we have a fair share of anticipated difficult airways. So these are patients who have limited mouth opening, sometimes have flap-based reconstructions. There's sometimes patients with cancer involving the posterior one-third of the tongue. And that's where, our laryngoscopes rest. And most of our residents, including JRs, are actually quite good and are at least able to do fiber optic bronchoscopy at the end of their first 3 or 4 months that they spend with us. Okay, so of course it has the cost of killing a lot of fiber scopes, but in general, they learn a key aspect of airway management fairly easily. Now in 2025, this year, we had a patient with the following airway phenotype. He was obese. He had a modified Mallampati class 3. In fact, our PAC does not allow you to save it unless you type this class in and it will not get saved. He had a history of cervical spine fixation, irradiation to the head neck region. And so from everywhere, this is a difficult airway written all over it. He came for redo neck dissection. So on one lazy afternoon in the hotspot, I was called. People had tried several attempts at anesthetized, long-acting relaxant intubation. There was blood in the airway, there was desaturation, it was difficult to mask ventilate. It was a complete mess. And if you think, that's I think one of the fundamental lessons, we almost always think, so if that guy can't intubate, I can. No. Always remember, when you encounter a difficult airway in this situation, you have to prepare for it. If somebody finds it difficult, you're likely to find it difficult as well. The airway was very difficult. So despite having a CMAC on spot, D blade, CL grade was 4. So we finally managed to intubate Bougie on the 3rd attempt. Now this 3rd attempt is very important because it's like the last possible attempt after which you have failed airway. And if you consider me an expert, it was very, very difficult to do. So what could have been done differently? Now we have a peculiar problem in anesthesia. We routinely use a dangerous class of drugs, neuromuscular blockers. Even if we don't use it, we use another very dangerous drug, which is propofol. And propofol is associated with sudden dramatic loss of airway control. So it almost always implies that when we are using these drugs, we should take the responsibility of meeting some form of oxygenation, whatever the method. But assuming we are using this drug, we must have a way of maintaining oxygenation at any cost before we start using these drugs. The problem is with testing. You may say the problem is with testing. Now, as you can see, if you just have class 4 Mallampati, you have a chance of a difficult airway is very low, 3%. You have a combination of factors, well, this chance improves, but overall prediction value of current testing is not good. So many times you may think there's a difficult airway, but actually there's not a difficult airway. In fact, it's actually studied, the ENTIS test, that if you predict there is not going to be but also do remember that if you predict there's going to be a difficult airway, if you predict there's going to be an easy airway, there's only 1% chance that the airway will actually be difficult. So there is some value in testing. Since no single test is predictive, sometimes we don't do any test at all. But if there is one message, even true for anybody, before you touch a patient, whether the patient's on the table, in PAC clinic, always remember to assess the airway. Because, in my 20, now close to more than 20 years of anesthesia practice, I've encountered only 1, 2 or 3 people who can be so rash they can manage any airway. So remaining maybe hundreds of people have encountered, all of us need to be more careful and conservative. If you're lazy and you don't want to do any tests, remember to do this upper lip bite test, because 91% predictive value. There is a chance that it's wrong only in 9% of cases. So if you one single test, but some testing is mandatory. So I did say, now this is data from the Western world. They've had BL, they have fiber optic laryngoscopy, but they still have a lot of adverse airway events, so sometimes they fail to use supraglottic device. Among the patients who have had failed airway management, a large percent, 50% will nearly die, So it's not as easy as we think. Despite having all the gadgetry, still remains very, very difficult to manage a failed airway. Okay, so now let's look at another different case. Just like in everywhere else, we're a government institution, we struggle to buy equipment. So this was a little while ago, in 2022 at Port Hospital, where we were running our service, and our VL fiberscope had not yet arrived. This is not exactly my patient, this is taken from a journal, but my patient looked very, very similar to this. He is a patient, he just came for some flap release, a simple procedure, and obviously tracheostomy was not the first option the surgeon would want to do. So, to feel good, I did manage to actually intubate this patient using a combination of volatile agent anesthesia, scopolamine, bougie. I don't remember exactly, but I did manage to intubate this patient. Surgery went on well. In about 25 minutes, the patient was extubated and was about to be shifted, when the anesthesia technician actually noted the patient was not responding. What we found is, because of the bulk of the flap, there was some kind of physical OSA. And at this point of time, the patient was not breathing. And I'm sure you have encountered this often. You have that low reading sound on a pulse oximeter with a low heart rate, and it's terrifying. Now, what is so important whenever you have a difficult airway, even if you're expert or think you're expert, never ever have an unplanned extubation. Because here, although we did manage to rescue this patient, near disaster was about to happen. So this reinforcement DAS extubation guideline. Now, okay, so just continuing on this thread, you have a difficult airway, you want to be conservative with extubation. So, you don't know where your enemy is going to come from. This is what the Chinese scholar said. So we had this person, our own patient. He was not actually very difficult to intubate nasally using a fiberscope. He had no comorbidities. He was being treated as Aveek's carcinoma. His chemotherapy had failed. And so now initial upfront surgery was being planned. We actually managed to intubate this patient very easily. To achieve patient parental separation, we gave ketamine, small amount of midazolam. Then we delivered SIVO through the one nostril and intubated through the other. We did have to do second pass intubation. We could pass a smaller than anticipated ETT. We expected 5.5, I think we expected 6, but we managed to intubate only with 5. Case was as such uneventful, very long, 18 hours. Everybody concerned was tired, residents, everything. I was not personally present on the spot after intubation, but everybody concerned was tired. Now, 4 or 5 hours after the patient was shifted to ICU, intubated, there was gradual but sustained desaturation. FiO2 was increased, beep was added, but the trend continued. This resident on the spot called the on-call consultant, who said, okay, we are not going to take a risk, we're going to ask for a surgical airway. But what, if you can piece all this data together, had happened is, over time, this patient actually had a blocked ET tube. The peak airway pressures are continuously going up. Nobody was putting alarms, etc., etc. Everybody wanted their share of sleep. And then, even as this artificial airway was planned, the patient arrested. And before we could revive him, he died. So what is actually required here is like a go back to the roots. You really need, whenever you manage airway, don't look at it as a unitary thing. Old-fashioned medicine is required. You need to be able to, do things like detect blocked endotracheal tube, pass suction catheters, do forced suction, call for help early. Remember, if you have a difficult airway, it will age with time. If you have a device, it too will age with time. It will get blocked, and your next pass airway, as 2 cases have shown, is going to be considerably more difficult than your first pass airway. Now, there's this whole new fashion, right, that we say, stop doing direct laryngoscopy, start doing video laryngoscopy. So the title of this, as you can say, says, old isn't gold, but new isn't always gold either. Now we have this peculiar problem that we have two coaxial tubes, right? From the first year MD resident to the last day we practice anesthesia, we could end up putting a tube in the wrong place, that is in the esophagus. That's just because the esophagus and trachea lie parallel to each other. At the same time, the trachea is offset from the esophagus. So it needs some effort to be deliberately putting a tube into the trachea. Blindly, a tube would go into the esophagus. This is like the fundamental baby principle we are all born with and will die with. There's and now because everybody's, there's only one way to dress. If you see the most common pair of trousers you would see on the street are a pair of jeans. We now practice almost always only Macintosh blade laryngoscopy. Now this blade has a big profile. So when you put a tube, you may see when you put the laryngoscope, you may see the larynx very well. But the moment you introduce the tube, you suddenly see I don't have such a good view of the larynx, and so this one-sided laryngoscopy brings a big share of problems. Now, so what is the alternative? Let's abandon DL everywhere. The VL, different types of VLs are always available. So consider doing VL. And now VLs come in different shapes and sizes and all that. We won't go into all of this. So in most situations in the Western world, they're saying do video laryngoscopy, don't do direct laryngoscopy. So video laryngoscopy, so much so that video laryngoscopy is standard of care. So if you were intubating a patient with DL, people might ask, why are you intubating with DL when VL is available? And you should only be doing VL. Now, for those of us who have used enough VL comes with its own share of problems. And this is not an uncommon problem. Even at our center, when people use it a lot, if you do it inserted blindly, you could end up with a big mess. So the problem here is, of course, pharyngeal, not so much pharyngeal wall injury, but during the process of intubation, if you have a tear like this, it will bleed. And when there's bleed, just like in laparoscopy, you just get such a terrible view that your whole feel-good factor disappears. What is definitely known, yes, VL always reduces the number of failed intubations, particularly so when you have a difficult airway, you have direct visualization of ET placement. What you're not sure about is the overall time taken to extubate. You may argue that as you get more experience, you may take less time, but study-wise, VL definitely takes more time to place the tube than DL. The number of attempts, we're not very sure, and if all of this, if it takes more time, it takes more there is a chance that you will get, the chance of hypoxia is not zero, and I'll show you more truth about this. And definitely there is a risk of trauma, and if you don't actually succeed with VL, and somebody tells you this is the only way to intubate, you may not use DL when actually DL may allow you to get a tube in faster or better. VL has been not shown to be as good as DL in situations which are really crash situations like a full stomach. It takes longer to intubate, and in the presence of apneic oxygenation, you're actually running out of time. Pregnancy, full stomach is more extreme. Infants, neonates shown VL isn't definitely not better, maybe equal, but it's definitely not better than DL. When you have such a crash situation as CPR, though it's not studied systematically, people have reported these problems, which we know will happen. Fogging is there, blood is there, you're struggling, and DL may actually allow you to intubate an easier airway faster. So I don't think it's a good idea to have this one-track mind about only one solution. So if there is one-track mind that is required, there's only one standard of care. My primary job of an anesthesiologist, oxygenation. Now, when that is your primary goal, there always has to be a plan B, which means if this laryngoscope doesn't work out, something else will. If this doesn't work out, the other thing will. So on. So after all, if you have a fire in a building, you can't manage it only one way. Now, this is all about testing, right? Here in the patient that I showed you in case 1, there was a predicted difficult airway. Whenever you predict a difficult airway, remember your chance of being wrong is only 2 in 3. So 1 in 3 patients in whom you predict a difficult airway, the airway will be difficult. So that's the critical importance of testing. Now, even look at it from the other side of the coin. If you do testing and you predict there's a difficult airway. Okay, even if it's the chance of it being a difficult airway is 1%, it's still that 1% you would pick up. So this is again and again to re-emphasize the importance of testing. Now, so let's look at this. Anytime somebody comes from the West, we think, oh, these are the real gurus. So this is a study that was published in Anesthesia Analysis fairly recently. It had a large number of patients. Despite knowing there was a difficult airway, 87% of the patients were anesthetized. Even when intubation was attempted awake, which means they were not done without anesthesia, 50% experienced hypoxemia, 71% used VL, 21% needed 3 or more attempts. So here is a situation where we see, so what is VL actually done? Even when we are doing awake fiber optic intubation, we tend to sedate them because we know, okay, if this doesn't work, we'll do VL. But result, half of the patients have hypoxemia. We attempt far too many anesthetized intubations, and in these anesthetized intubations, when VL was used, we take 3 attempts so many times. So 21% of patients need 3 or more attempts. So you're essentially scoring 80 out of 100 in an exam, where if you score 0, if something happens to you, you're dead. So it makes sense to be humble and look at so primary purpose of anesthesia is oxygenation. So how many of us would, if you ask an anesthesia trainee in their exit, what are the predictors of difficult mask ventilation? I am fairly confident they will not be able to tell. Now, if there is something to learn, yes, these are known predictors. So if I want to assess any patient, these are the first factors I need to look at. Is there going to be predicted difficult mask ventilation? Very good study from Khetrapal, large number of patients, and all of this. So Mallampati class here is very important because it predicts difficult mask. Predictors of very, very difficult mask in ventilation. So be very careful when you have a patient, however level of expertise you have. Okay, and of course, we won't go into this slide. There is another principle to be unlearned. So the moment you convert to this asleep intubation, and you have assured yourself mask ventilation is not going to be difficult, give relaxant, because relaxant makes mask ventilation. So important to emphasize this big principle. Now, I'm running out of time, so let's just talk about another extra case. So let me go back to my first case. So we had this patient, I've already spoken about him. The surgeon struggled with neck dissection. Case went on for 3-4 hours. As the guy in the cockpit, I thought I did what was fairly standard. I stayed till the end of the case, practiced the DAS airway guidelines, extubated the patient awake with an airway exchange in place. Once he was stable, I shifted him to ICU. I thought I'd put HFNO, but he was maintaining oxygenation with nasal oxygen, so I said, why would I do something which is not required? And I sort of went home. About 2 hours later, I got a call from I stay very close to the hospital. The patient had asystole, CPR was ongoing, and they were finding it, like I had found initially, impossible to intubate. So again, I went to hospital. I did intubate the patient. Now in the crash situation of CPR, all the problems of VL still there. The patient suffered hypoxic ischemic encephalopathy and finally decided to withdraw care on the 7th post-op day. So what is important here is not actually airway, is this whole 360-degree perspective which we call situational awareness. So patient was well and talking, there was no stridor or any sign of distress. So I just went home. But 2 hours after surgery, and here sadly there were more experienced people on the spot, the patient started to desaturate. It was they suspected he was having some kind of acute coronary event. It's very difficult to say actually what happened. So if you have a difficult airway experiencing another related difficult situation, what would you do? So in hindsight, you would do this today. Even if you extubate this patient, keep him HFNO for some time. So you have some backup plan. But any case, once you start desaturation, start ramping up things fast. Start HFNO immediately. HFNO is not working as HFNO is being tried NIV. NIV is failing, say I'm going to do a awake fiber optic intubation with NIV through a whole mask type of NIV. Now, none of this was done. And this is very important because when your patient starts to desaturate, you're on the steep portion of the hemoglobin oxygen dissociation curve, and you'll fall fast and fall to the bottom. So whenever you have a difficult airway plus another problem, be very, very careful. The airway is actually not at all about intubation. It's about patients. In this trial, landmark study showed when you actually intubate sick patients, not difficult airway patients, easy airway, sick patients, 45%, nearly half of the patient have some or the other adverse event. 42% have hemodynamic instability, 9% have hypoxia, and 3% die. So overall, at the end of the study, 1/3 of these patients died. So it's obvious that even though we probably manage the airway, easy airways, we're missing the larger picture in airway management. So what is now really required? I'll just take 2 minutes. I don't think we are doing this well. When we teach people difficult airway, we teach them how to do fibroscopy, how to do this, how to do that. But we're not teaching them this 360-degree perspective. Unless we teach them principles, we can never expect any real life-changing experience. So we have to do this, and this is actually the main part of my talk. So young learners have to keep practicing skills. They have to analyze scenarios, get tested, practice in the presence of secure. But older people like me, we have to devise algorithms, test that they work in our workplace, focus on weaknesses. So this is a patient we failed in. How are we going to improve? Organize our own skills because we are going to be backup. Make local algorithms. So everybody has a job to do which we are not doing. We need to clearly reorient to the primary target, which is oxygen, which means use LMAs. They're old-fashioned, but they could really be life-changing. And they've been shown to be life-changing. Don't be fixated just on devices. Use HFNO. It's a new kid on the block. It works well. There are some new tech solutions which you should be able to do easily when challenged. So finally, it's not about intubations, it's about quality in healthcare. For patients, what is required? Safety and quality. Now you imagine we are a tertiary referral cancer center, and I gave you an example of at least 2 patients who we failed. So we are clearly not there. For healthcare workers, there is another principle that I would like to emphasize. It's all not about beating people. It's also about taking care of each other, taking care of ourselves. Now the ISA has started looking at this, and this is also very, very crucial when we have something as dangerous as the airway. We must have audits, but not the way we do audits in India, which is to blame the junior most person. As you can see in this photograph, when the first ISRO launches were planned, Abdul Kalam was the mission director, and the first rocket he built went into the Bay of Bengal. But who took responsibility? His boss, Satish Dhawan. When Abdul Kalam succeeded, who went and attended the press conference? Abdul Kalam, not Satish Dhawan. So that kind of culture is something we have to bring to our country. Remember, airway management actually doesn't test skills, it also tests you. So you have to be able to be very healthy and happy to be able to manage in crisis. Some of the things you've tried: breathe deeply, share tasks, talk to yourself, practice comfort care. So if there is one take-home slide from all of this is not about devices, not about techniques, it's about you. And if you take care of yourself, you'll be a very good airway manager.